Good afternoon. This is a Neuroscience 2 non-Alzheimer's disease dementia imaging session. My name is Satoshi Minoshima. I'm from the University of Utah. All right, so we're going to move on to the next talk by Dr. Yassi. And he's going to talk about vascular cognitive impairment MRI findings. Dr. Yassi.
Well, thank you, and good afternoon. And it's great to follow on from Professor Chen, who presented such a fantastic overview. I'll do my best to avoid repetition. I'm going to talk to you a little bit about, again, what is this construct of vascular cognitive impairment and how can we understand it in a clinically relevant way, and also how can we use MRI day to day to help us out. As a disclaimer, I'm not a radiologist. I'm a neurologist, and so I'm not giving necessarily a technical overview, but more of a clinically relevant overview, hopefully. So this traditional construct of vascular dementia is something, again, that Chris discussed, and I'm hoping to argue to you this morning that this is not really a very helpful construct. So the old definition of vascular dementia being that it is a dementia process usually characterized by a stepwise clinical deterioration as a result of sequential ischemic or hemorrhagic strokes, and having a particular neurocognitive flavor that's particularly affecting executive function, attention, affect, gait, and potentially others based on where the infarct lesions are. This is not a particularly helpful way to think about vascular cognitive impairment because, as Chris said, it really under-recognizes the overall burden of cerebrovascular disease. The other issue is that typically vascular disease, vascular dementia has been thought of as being separate to the other dementias. So we've traditionally thought of, people having Alzheimer's disease or people having vascular dementia or dementia with Lewy bodies, as Rosie will talk about later, FTD. But in reality, that's not actually the case because as this study and many others have shown, as people get older, and typically people presenting with cognitive impairment are 65 and older, people begin to accumulate not just one, but multiple disease conditions. And the more accurate way to consider vascular dementia is in terms of how it contributes to a variety of other neurodegenerative conditions. I am a stroke neurologist, and I spend most of my time looking after people with acute stroke. And the two main categories of acute ischemic stroke are ischemic stroke and intracerebral hemorrhage. And depending on where in the world you come from, the prevalence of each of these is different. So in a country like Australia, it's 80% ischemic stroke. In some Asian countries, it's 50% intracerebral hemorrhage or even higher. If you've had anything to do with stroke in the last 4 or 5 years, you can't have missed this new revolution in acute stroke treatment, which is endovascular therapy for large vessel occlusion. And so this is a procedure through an angiogram with patients usually awake of removing clot from large vessel occlusions. And this has really revolutionized the field of acute ischemic stroke. Multiple trials in 2015 demonstrating benefit of endovascular therapy, including our own Australian trial, Extend-IA. And more recently, just this year, the therapy has been extended to more extended time windows beyond 6 hours using advanced imaging with CT perfusion to identify viable brain tissue with 2 new trials. Now, stroke obviously takes up a lot of time for a stroke clinician and is very acutely disabling and has a high mortality and high morbidity. But if we only consider acute stroke, you saw a very similar graph to this from Chris, we really miss a massive burden of cerebrovascular disease that's under the surface. And so a way to think about cerebrovascular disease is to think about how it contributes to cognitive impairment and dementia in its many different ways. So the old-fashioned definition of multi-infarct dementia or vascular cognitive impairment after a single strategic infarct is only one part of the picture, and the rest of the picture is really what does the burden of small vessel disease, including white matter hyperintensities, silent brain infarcts, lacunar infarcts, have on cognition? What is the burden of chronic hypoperfusion, of hemorrhagic lesions, including microbleeds? And so I'd like to sort of propose to you that it's more useful to think about cerebrovascular disease in terms of not only how it causes dementia in and of itself, but how it contributes in a range of other neurodegenerative diseases, which is something we're trying to study in Alzheimer's disease, in dementia with Lewy bodies, and in other conditions at the moment. So there are numerous categories or pathologies, if you like, of cerebrovascular disease, and I'll show you some of the clinically available imaging modalities that we use to image some of these. So cortical infarctions, subcortical infarctions, microinfarcts, very briefly, white matter hyperintensities, hemorrhagic lesions, and perfusion abnormalities. So this is an acute brain infarct in the left corona radiata. This is this typical lacunar infarct. They always look larger when they're acute because they're edematous, and we use diffusion-weighted imaging here to image the restricted diffusion of water due to the acute infarction. So they look bright on diffusion-weighted imaging. These are classically taught to be the result of lipohyalinosis in these small perforating vessels which come off the middle cerebral artery. But we now know that they actually can be caused also by atherosclerosis in the larger arteries, so parent vessel atherosclerosis, and possibly even can be caused by embolism from the heart or from a larger vessel. So we've been looking at these lacunar infarcts using a 7T study here in Melbourne, and this is an example of a patient from this study where you see here this acute lacunar infarct in the left internal capsule, and you can see here this non-contrast MRA, so without injection of any contrast. This is completely contrast-free, and you can actually image the perforating vessels on 7T, which is quite nice, as opposed to 3T where they're usually invisible. And in this patient, we've been able to identify this atherosclerotic plaque in a small branch of the middle cerebral artery. So this is not a classic lipohyalinosis. It's a case of parent vessel atherosclerosis in this small vessel. This is not a lacunar infarct. This is a large vessel infarct. So this is the kind of stroke that would be amenable to clot retrieval. Now, this video is meant to play on repeat, so I'm not sure if anyone on the sound desk can put it onto repeat. But basically, this is a perfusion MRI using contrast. So it's called a dynamic contrast-enhanced perfusion MRI. And if the video were to play, you would see contrast travel through this slice of brain. And in the right hemisphere, there is actually a delay in contrast arrival, which is mapped out here on a time-to-peak map. And this shows us that this right hemisphere is ischemic and under threat of infarction. And within this area of infarction is a small area here where blood is not getting at all, and this is the ischemic core. So that's contrast-enhanced perfusion. There's also a lot of interest in another form of perfusion imaging called arterial spin labeling, and this doesn't require the injection of any contrast. And so this actually relies on labeling protons in the blood with a radiofrequency pulse, and then after a short delay, acquiring an image. And so you end up with a control image and a labeled image, and the difference between those two is called a perfusion-weighted image, which we can actually produce similar color maps of brain perfusion. And this is quite nice because it's available and can be acquired at the same time as a standard MRI with most clinical scanners. And there is, as you might appreciate, and as you may well have seen, a lot of interest in using perfusion ASL in neurodegenerative diseases. And this study and others have shown that that the changes on perfusion ASL actually map quite closely to what you would find on FDG PET in people with Alzheimer's disease. Okay, so that's acute stroke and perfusion. Chris mentioned the beneath the surface of the iceberg, these silent brain infarcts, which don't present with an acute clinical syndrome, but are still associated with a risk of cognitive impairment. And so here we have on a FLAIR image an infarct in the right temporal lobe, which was silent, and a patient here with 2 subcortical silent lacunar infarcts. As you heard, silent brain infarcts are about 5 times the prevalence of clinical stroke. And you can see here in population cohorts of healthy middle to older age adults, the prevalence is actually quite high. So once you hit about 70 or 80, we're talking about 15% prevalence of people who have a silent brain infarct. So they're an important type of lesion. They are, as I said, associated with a risk of stroke, clinical stroke, as well as a risk of dementia and of early death. And this is an important paper now, quite an old paper from the Rotterdam study, where they showed that the risk of subsequent dementia is more than doubled if someone has a silent brain infarct. Chris spoke very well about cerebral microinfarcts, and there is quite a lot of interest in identifying these lesions in 3T MRIs. And so this is some of the early work from the Utrecht group. Really quite nice studies, including ex vivo MRIs where these lesions were characterized on 7T and then subsequently histopathologically proven to be microinfarcts. The presence of microinfarcts is associated with a diagnosis of Alzheimer's disease, and as you saw, they are now detectable with standard 3T scanners, and these are some of the examples on. So what's required is really not beyond the resolution of anything that a 3T clinical scanner can provide. So you really just require a high-resolution T1 and a high-resolution FLAIR, and you can see them here as these sort of punched-out lesions perpendicular to the grey matter, and they usually look bright on FLAIR, or they can be iso-intense. And this is the next slide is an example of a microinfarct from one of our in-house studies. If it will do what it's told. There we are. Okay, so this is we're currently looking at participants in the ABLE study, looking for these microinfarcts, and this is an example of one of these lesions in an ABLE participant. Okay, can you jump to the next slide? Thank you. White matter hyperintensities are a common type of lesion, and Chris, I think cover this very well. The difficulty with white matter hyperintensities is that they're also very common in otherwise healthy people, and so the difficulty, I think, the challenge for the field is taking things from a population level to an individual level and trying to understand what the relevance is of finding these hyperintensities in someone who presents either with normal cognition or with mild cognitive impairment or with dementia, and what it means for the individual patient is difficult. Having said that, on a group level, they are very clearly associated with a risk of cognitive decline in multiple domains. Here is an example of another patient with white matter hyperintensities and with a silent brain infarct. And if you're interested, I'll give a plug to a poster that's being presented today in the neurosciences section, looking at white matter hyperintensities in the ABLE study. Next slide, thank you. Okay. They are, as I said, associated with different with impairments in different cognitive domains, both in AD and in mild cognitive impairment. Oops. The other interesting thing that we can image is arterial abnormalities, particularly atherosclerosis being the most common. And so again, this is an example of a time of flight MRA, so requiring no intravenous contrast, demonstrating atherosclerosis in the terminal internal carotid and here in the middle cerebral artery, and then confirmed on formal angiography. One of the new things in the field of arterial imaging is so-called vessel wall imaging. So this is a post-contrast sequence where you can actually image, after giving contrast, you can actually image the vessel wall. And in the setting of atherosclerosis, which you can see here on a standard MRA, in the setting of atherosclerosis, you get enhancement, this eccentric enhancement in the wall of the vessel that reflects atherosclerosis. And that can distinguish these lesions from, for example, a vasculitis, where you would have concentric enhancement in the vessel wall. So there's a lot of interest in this at the moment. Okay, the other end of the spectrum is hemorrhage, and so as I said, this is the other type of stroke, and these are CT images, obviously, but this is acute hemorrhage in the right basal ganglia and the cerebellum, typically associated with hypertension, and this is hemorrhage in the parieto-occipital area, a lobar hemorrhage, which is more typically associated with amyloid angiopathy, and this type of hemorrhage has been clinically recognized more often in the last 10 years or so. This is so-called a convexity subarachnoid hemorrhage, which is blood on the surface of the brain in the subarachnoid space, which is a correlate of superficial siderosis on MRI, and that's typically, again, associated with amyloid angiopathy in the elderly age group. We can image hemorrhage on MRI using susceptibility weighted imaging based on the changes that iron in the blood have on susceptibility of MR images. Whoops. Next slide. Next one again. And what we see on susceptibility weighted imaging here is these lobar microhemorrhages, which are typical of cerebral amyloid angiopathy, as well as these blood in the sulci here, these superficial siderosis, again typical of cerebral amyloid angiopathy. On this slide, you see multiple microhemorrhages in the deeper structures, so in the basal ganglia, and this is typical of hypertension. Now, you may have heard of quantitative susceptibility mapping, and this is a technique where you combine the susceptibility images with the phase maps that are generated by the scanner, and you're able to actually quantify the amount of iron in different parts of the brain, and there's also some interest in using this to look at neurodegenerative disorders. Next slide. So I hope I've shown you that a more useful way to appreciate cerebrovascular disease using imaging is not just to look at infarction or microbleeds or white matter hyperintensities, but actually to consider how everything acts together and how different types of pathology might contribute to someone's cognition. And this is something that we and others are working on at the moment to try to really bring together all the different patterns of ischemic and hemorrhagic pathology that you can pick up on imaging to bring it into a single score that can give us an idea of the vascular contributions to cognition. Next slide. And this is the last slide, and again, very important to consider this in the setting of other conditions, particularly Alzheimer's disease. How do all of these lesions contribute not only to the clinical picture of Alzheimer's disease and other neurodegenerative pathologies, but even potentially to the underlying biology? Thank you.